Just going through matters of housekeeping. This is a live meeting. It is being recorded. The press are most probably watching. Please can I ask all microphones be placed on mute throughout, unless when you're speaking, and then unmute. Can I ask commission members and special guests to keep their cameras on? Please raise your hand if you'd like to get my attention, or in the chat function, just write a question. But otherwise, other than that, please don't use the chat function for anything other than that. Everyone will be aware that there was a cyber attack to the council. That is still an ongoing investigation. So I've been asked, and I will kindly make sure there are no questions in relation to that. There will, of course, be a time when it's appropriate for this and other committees to ask questions and seek assurances. That's just not right now while an active investigation is going on. I haven't been notified of any declarations of interest from the health members. CYP, any brief declarations? No, thank you very much. Well then, without any further ado, can I move straight on to item 4, which is the integrated children and young people's workstream, and welcome to Amy Wilkinson, who's the workstream director. Amy, if possible, can keep the presentation to no more than 10 minutes. And I will finish this at 9:45 because we have got a packed agenda. But after Amy's done her presentation, we'll go for questions. Amy, over to you.
Yeah, totally. So I'm going to assume that you've all read the papers and most of what is relevant is in there. I think it's probably most useful to focus on some of the COVID elements of the workstream. And while we've been continuing to deliver on our business as usual, working to progress the adverse childhood experience and the neighbourhoods agendas, predominantly more long term, our COVID response has focused on sort of 5 key areas, and those are around safeguarding, I looked after children, a universal response. So there's an example there from health visiting. Mental health and emotional health and wellbeing have done a huge response, including sort of expediting online offers and digital offers and a bereavement service. We've also had some interesting times with the inpatient ward and the Homerton response as well, and striking a balance between supporting adult services and also ensuring that we've still got safe and accessible services for children and young people. And lastly, just to flag, I'm sure you're totally aware of the issue around childhood immunisations. So what we've seen is a decrease of somewhere between 25 and 40% in City and Hackney of routine childhood immunisations, including flu. That's mirrored across most of North East London, and CCG's invested significantly in terms of trying to address that. We've managed to get our health visitors planning to immunise in children's centres and are doing a joint response, which hopefully will be successful over the following few weeks up until Christmas. So I'll leave the presentation there, but feel free to discuss and ask anything you'd like.
Thank you very much, Amy. During the pre-meet, I certainly had questions from Cllr Conway and Cllr Etti. I'll go first to Cllr Conway. Cllr Conway, sorry to put you on the spot. You raised but I think when we were discussing before, you raised an important point about virtual support for mental health services during.
I did, yes. Can you hear me?
Yeah.
Sorry, I have been having some connectivity problems. I just wanted to flag up that young people talking to the CYP Commission in June suggested that there may be some reluctance by young people to engage with mental health support via online services. Assuming that virtual appointments are here to stay in some form, what assurance can be provided to the Commission around the take-up and efficacy of local CAMHS services, and are virtual health services reaching all sections of the community equally? And quite specifically, this was sort of in reference to, I think, in reference to a young person who had explained that she knew of friends who were struggling to access these services virtually because of issues with not having space to have confidential conversations with anybody at home. Yes, thank you.
Do you want me to say that now?
Yes, please.
Yeah. So I actually remember that session. So we looked at this in May with this CYP scrutiny, and it was a really relevant point. So initially, as a quick pandemic response, services did all go virtual, including CAMHS services, and were very quiet for some time. And at that point, we brought the online services on quite quickly. Since then, CAMHS have gone back to face-to-face appointments. They've always seen children and young people face-to-face where there's been crisis or where they've been concerned about them. And they are very keen, as we go into the second peak or whatever we want to call it, that we don't resume to a virtual by default offer. So they will be prioritising face-to-face and continuing to do that. We're ready for a big surge sort of post-September, October in terms of referrals to services. And the capacity is there at the moment to do that. There's also the DFE, wellbeing, education support going in, and WAMS in September is now an all apart from a handful of schools, and our mental health support teams are back in schools physically from September as well. So we're hoping that it will be a lot more solid than the initial response was.
And Amy, just on that point, what is the time it takes to get an appointment or a referral? So if I want to, I'm not 100% sure how the referral pathway works and whether it can be self-referral or via the GP or the school. How long am I waiting before I can speak to a professional?
I mean, it depends completely on what the issue is and the route of referral, but there's a 24/7 crisis line. There's face-to-face crisis appointments, 9 AM to 9 PM every day. So it should be really quick, but I can go back and confirm.
Yeah, you can just give us some idea that, for example, there's not sort of a number of weeks or going into months sort of wait before any form of meaningful support can be provided, just to keep an eye on that.
And get back to you. We've done a lot of work on our access times, and they're much shorter than other areas, but we're hoping that it's less than a couple of weeks.
And just one final piggybacking on that. I mean, post the sort of the first wave, there was obviously concern about people, children under the radar without their usual support and monitoring from schools. I mean, did you see at that point, did you see an uptick of referrals? Did you see more of the gravity of cases that were coming through because there hadn't been that support during the period?
No, so what concerned us is that we didn't see the kind of upswing in referrals that we had expected at the time, and were anticipating that would be kind of September, October. So still waiting for that. In terms of more generally, we do know that families are, there's increasing referrals in terms of domestic violence, and some of those things starting to come through. We've also, our commissioned bereavement service has just seen a handful of children and young people, so we're anticipating that will increase in referrals as well shortly.
Thank you. Councillor Etti, you also raised a question in the pre-meet as well. Do you want to ask?
Thank you, Chair. Thank you, Amy. My question was, is actually on what is written when you're talking about the prevention offer. And I just wanted more explanation on the practicality of the prevention offer to children and young people. And secondly, with regards to the decline in the decrease in child immunization that you've talked about, what other plan do we have in place in terms of engaging with parents, in order to increase that? What other plans do we have in place in order to increase that because of the current pandemic? Thank you.
So can you be a little bit more specific about which element of the prevention offer you're referring to? But
it's under improving children and young people emotional health and well-being across the system. And I'm thinking, when we're talking about prevention of let's assume, okay, probably mental health or COVID or anything. So in terms of the practicality, I just want an example to elaborate that. Thank you.
Okay, so we've been rolling out trauma-informed training for all teachers and staff in schools. So helping them to learn how to identify issues that might be mental health as opposed to being behavioural. So that's been going since the beginning of COVID. They've had excellent take-up, and they're in all schools. And the DFE offer actually builds on that quite well, along with the workshops from Anna Freud and the first phase of the wellbeing and mental health in schools work. So some support for teachers initially is where we're starting, but helping them to help their classes as well. We've also done, you've probably seen comms in some of the Hackney papers as well about getting ready to go back to school with links to our CAMHS services and how to access them, and the crisis lines as well. In terms of immunisations, so there's been a lot of comms. We did a back to school comms campaign. There's now a flu campaign. We supporting primary care, so GPs to do additional vaccines as much as they can, and doing comms with parents through schools, but more widely as well. And I mentioned earlier, our health visitors have just been commissioned to deliver in 8 children's centres in the car parks between mid-November and Christmas, and also in the City Children's Centre. And they will do flu vaccines initially and estimate that they can do about 2,500 for 2 and 3-year-olds. They'll also work with families, and we will hopefully be able to use that as a vehicle for delivering childhood immunisations like measles, mumps and rubella following that.
Thanks, Amy. Just on that, just following on that second point, where are we? There's been long problems since the measles outbreak, and you could even say now that we're seeing it in real time with COVID about data flows, tests coming back, and for measles it was the centralised data as to who had it and thus being able to respond. Have things there improved in terms of data flows as to who's been vaccinated or not?
Yeah, so the GP Confederation, as part of their commission, are doing some work around data. So they are locating all of the data sources and data points, and there are a range of those. So, so a child might have a record at the GP, or they might have a record with the health visitor. They might have a record on another system. So there are a number of systems that are in use, and the Confed has got a post that is looking to streamline that data and get that all in one place as we speak. So hopefully there'll be some improvements in that.
And is there a message about the importance of having the flu vaccine at this point at time of COVID, or is it just that is your concern that you're worried that because there's so much focus on COVID, the numbers have dropped, and you're worried about, say, the reoccurrence of measles or the flu, or is there a real concern, or it may impact more on the older population, that if you get COVID at the same time as you've got the flu, there are worse health outcomes? So can you elaborate any more on that?
Yeah, so there's a few things. We know that historically we've had low rates of childhood vaccinations leading to a measles outbreak. So the very last thing that we need at the moment, going into a winter of COVID, is another outbreak of infectious diseases. So we need to do all that we can to do that. And we would have done that anyway, except that we've seen that drop due to COVID that other areas have seen as well. And part of that is around, it's been reluctance by families, completely understandably, to access health systems, I guess not knowing if primary care is open. And while we've had a really good response in City and Hackney, there's still a bit of work to do, I think, with families and the general public about the NHS is open, please access. It's much better to access to GP than to end up in A&E, particularly with children and families. The other thing is around reducing pressure on the NHS, and obviously the more people are vaccinated against the flu, the more kind of space there is in the health system to deal with COVID patients. Those are the key elements. The other things that we're a little bit concerned about going into winter capacity on the children's inpatient ward. So we repurposed that in mid-outbreak to deal with adult COVID patients, and that's around Homerton Estate. So we would normally have a winter contingency plan to put that in place and to use the Royal London for any inpatients where we were over and above our bed numbers. So obviously our neighbours are going to be stretched as well. So that's one of the elements that we need to plan for. And just as many people as immunised, the better in terms of all of those factors.
Thanks, Amy. Councillor Gordon.
Thank you very much, Chair. sorry, I'm actually going back to the CAMHS services. I mean, it's good to hear about the programme of engagement with young people based on co-production and valuing young people's engagement in developing services. It'd be also interesting to hear if there's any plans to evaluate and learn from this programme and to extend the learning and improving engagement. I mean, it just if you could just talk about that a little bit, about how you're going to learn and engage with young people and service users to evaluate the service. Thank you.
So we are going to work with our program of system influencers, and that's working with Roni and the and all of the COVID conversations, building on that in terms of designing an evaluation that will tell us what we need to do. There's been lots of pockets of engagement, I think, in terms of health across the years, and this gives us a chance to think about that, join it up a little bit more, and to make sure that we're getting answers to the questions that we need. So there's been some really helpful engagement with young people that you'll be aware of around COVID, and they've told us some great stuff about what they'd like to see in terms of health system. So we'll use that in building our evaluation.
Thank you. Any other members for questions? I can't quite see everyone on the grid at the moment. I've got Mr. Alexander. Mr. Alexander, can you just unmute yourself, Mr. Alexander?
Okay, I just wondered whether there was any evidence of resistance to flu vaccination. I mean, historically, there's been a lot of resistance, even amongst health professionals. First of all, is there evidence at the moment of resistance to taking vaccination? And secondly, is data collected? Is there ongoing data collected by ward across the borough, so that you can see if there's any particular areas of resistance?
Yeah, so there's always been some vaccine resistance, and I think we did a campaign maybe last year around vaccination, and it was the council's it got the most hits ever on a Facebook page. It was about promoting vaccination, and there's definitely still some anti-vaccination sort of sentiment out there, as there is in all areas, in all boroughs. We don't necessarily know that exists at sort of ground level in terms of what families are telling us, or whether it's just that they don't turn up. So you often can't pinpoint that that's what it is. But one of the pieces of work that I've been piloting in the northeast, so one of the PCNs there has been doing some work around vaccine hesitancy, and talking to the confed around doing some training for frontline practitioners and for GPs and those in surgeries. So that's Tessim's CAMHS work, which we'd like to scale up as well.
Thank you. Any other questions, Councillor
Knowing
Snell?
data in terms of by ward?
Sorry.
So we've got data by ward, but we don't have data on vaccine hesitancy, because often people won't say that that's the reason that they're not vaccinating. So we can see, numbers generally.
Okay.
Councillor Snell.
Thank you very much.
Councillor Snell. You're muted. Oh, thank you.
Sorry, so I'm going to repeat the same complaint that I made at the last meeting, and as is minuted from the last meeting. And it's basically that it's wonderful to get these workstream reports, but they are the most impenetrable reports we ever get. And if I, as a councillor on this committee, have to think twice about what CAMHS means, you know, there is one thing after another where I'm searching for what the letters mean. And surely it's easier to just call something a review rather than ASR or whatever it gets called in many cases. And if we are going to have all these are supposed to explain to the general public what we do, and they're opaque. Now, we had a fantastic report, as we always have, from Health Wash Hackney at the last meeting, which was as clear as anything. We've got another fantastic report tonight from Adult Safeguarding, which is as clear and accessible as we could possibly be. And I just beg you, please, this may make perfect sense to all your partners, but it does not in its current format make sense. And I said the same at the last meeting, but these are supposed to explain to people what we're doing. And unfortunately, the appendices and that generally are a lot more accessible than the introductions. But the introductions assume too much knowledge, and they really are difficult for me to read through, even let alone understand. So just a plea for the future, please. You don't have to reply.
Sorry about that.
Okay. Any other questions? Amy, I was going to ask, in terms of maternity, can you just remind me what the Homerton's policy was during the first outbreak in terms of partners attending scans and also being there at birth, and what planning has gone into that depending on where we end up in this wave?
Yeah, we've seen some really interesting things with maternity. So we've worked really closely with North East London partners across children's and across maternity throughout the pandemic. So initially, in terms of maternity, it was very much virtual appointments for antenatal and postnatal pathways, one birth partner, no visiting, no partners in scanning initially. That was the initial response. Apart from where they were concerned about women, so vulnerable, safeguarding women, or domestic violence women, and that would have been face-to-face. Subsequently, slowly they've introduced policies around they can now be two partners at the birth. Visiting is between 2 and 5, I think, at the moment, so 3 hours every day. Visitors can come on the postnatal ward, and then antenatally they're starting to reintroduce face-to-face appointments as much as they can. So things are definitely, we were preparing to kind of restore, really, and now we're sort of balancing restoring with possibly a second peak. So what the conversations that have been happening across North East London is that most trusts are in a similar position. Some have got slightly different arrangements, so maybe less visiting or no partners scanning yet. The Homerton have been quite accommodating in terms of that. One of the things that's worth flagging, though, is that in April, May, so in the peak, we saw our bookings at the Homerton, maternity bookings, rise by about 20% on what we would normally deliver in a month, and just watched and waited for that, and it's fed through. So now we're seeing about 150 extra deliveries for October and November, so we're really going to be stretched for capacity there, including implementing kind of infection control procedures as well as doing safe births. So it's definitely one to watch, but they are ready to reinstate kind of virtual appointments, to be stricter on the visiting and reinstate all of those infection control measures. But I guess a kind of a snapshot in terms of the way that the pandemic is moving is that for the last 2 months, we've not seen any COVID positive women coming to birth, and in the last 2 to 3 weeks we've seen a handful, so 2 or 3, now 4 women who are pregnant coming through, and they tend to be asymptomatic women who are being tested. So they're testing all women who are having planned cesareans, screening all partners, and then testing anybody who's symptomatic as well.
Fine, that's very helpful. Just a couple of questions, and I know your Councillor Conway has got another question as well. Just coming out, what was the cause of the Homerton getting that upsurge in bookings? And presumably that must have been to the detriment or of another trust or hospital.
Yeah. So there was go on.
And then the other question is, can I just be clear? So the point during first peak was that for the scans, partners couldn't attend, but during the actual birth itself, during the first peak, were partners able to attend the birth, or was that stopped for a period as well? So just to be clear.
So that was stopped for a very short period, and we were right in the peak in April, but then they reinstated one partner attending quite quickly, and now 2 partners can attend the birth. So sometimes that'll be a doula or another partner or whatever that is. The first question, so what we think that upswing was so about 70% of our Hackney women birth at the Homerton generally, and roughly 30 birth elsewhere, and a big chunk of that elsewhere cohort is UCL. And what we think we were seeing was women who had started to work from home, who would possibly have birthed at UCL but booking closer to home to have antenatal care, in Hackney, and so we thought that once people got back to work that might change, but it hasn't changed at all. So I think that's what that is. Our Northeast London partners have seen small reductions, but I'm not sure what UCL has seen, but they do have quite a big attrition rate generally anyway.
Fine. And has that meant that the maternity suite goes on red or whatever it is, where it can't, where people are essentially there isn't capacity there, and then they have to go to other hospitals?
Yeah. So for October, November, the Homerton are not taking any kind of late bookings from out of areas. They will obviously take emergencies coming to the NICU and women who are already booked, but that's the position for October, November. The deliveries for December look more normal, and yeah, it's 2 months.
Fine. And just to be absolutely clear, if we get second peak and it's as bad as it was in April, and the hospital is very stretched, for scans, if I've understood you correctly, might we go to no partners or not? And what is currently the plan on birthing? Would they still be allowed one partner, or would the plan, if we get as bad as we were in first peak, might we be in a situation where no partners can attend the birth?
So it changes every week, and the decisions are made at trust level in conversation with our neighbours. But generally, yes, they would probably reduce to no partners scanning and probably one in birth. That's the most likely scenario. But they're reluctant, as with CAMHS and wellbeing services, reluctant to revert to that very kind of skeletal situation. But they would if they had to.
Fine. Thanks for that. Councillor Conway.
Thank you, Chair. Given that early years is a stated priority in the report, and given the centrality of local children's centres in the delivery of our integrated health, education and early help offer, how is the integrated CYPM commissioning workstream working with local providers to ensure that local coverage and reach of children's centres is maintained? Will the planned neighbourhoods approach to service delivery offer opportunities for increased investment in this vital early years resource?
Yeah, we hope so. So the neighbourhoods agenda is something that we've worked on for a long time in terms of how that will fit with the Children's Centre agenda, and worked really closely with Donna Thomas and her team to design the neighbourhoods offer. So what they already have quite a strong health offer, an integrated health check. They have midwifery and health visiting delivered from children's centres. They have a range of speech and language and OT as well. What we'd like to see is them starting to move a bit more on immunisations, which would be really positive, and we'll trial that over the next couple of weeks. So it's definitely still a high priority, and there's a lot of room to move in that arena, and I hope that through the neighbourhoods work we can move that on.
Thank you. I've got further questions from Councillor Gordon.
Thanks very much. I mean, obviously it's a rollercoaster time for everyone, but I mean, particularly for women and their families who are about to give birth, the uncertainty must put a great additional pressures to them, both in the pre and postnatal period. I mean, what have you seen a need for sort of additional mental health support for women and their families from health visitors? I mean, what sort of findings have you had about that and the provision? I mean, it's very difficult not being able to, you're not being able to plan your birth in the best of times. So I mean, I think it must be, and the prospect of being there without your partner must be very, must give additional stress to, to women and their families.
Yeah, it's really difficult, and you're really right to raise it. So all the pathway for women who have just given birth or new mums has been highlighted by lots and lots of different organisations to say that they're really concerned about that. So we've flagged that up at North East London level. GPs are concerned because they're not seeing them as much face to face, and health visitors are really stretched across obviously a COVID response. Some of their staff are still shielding and self-isolating, but prioritising safeguarding, and then also the new birth visits. So we're really aware that that's a key area. There is some perinatal mental health support that we've put in and put in a bid to the STP to strengthen that. So it's somewhere, there is support. I think we need to do a bit more work on it though.
Thank you.
And good to hear more about that, so thank you.
Councillor Etti?
Yeah, thank you, Chair. I'll take Amy just back to the neighbourhood funding, the one you talked about. And I can, from what I have read here, it's just for 1 year in terms of 1 year project manager. And I'm just thinking, when you're looking at wanting to deliver the integrated services and you only have a position for 1 year, does that seem a serious commitment with that program when it's only for 1 year and you'll be working with 0 to 5 years old and all that?
Just to go, have you finished? Sorry, you finished, Councillor?
Yes, please.
Just to explain, this is in relation to page 15 on the agenda, I think. There's a Neighbourhoods Project Manager who's been appointed for 1 year to, I think, embed the work stream at neighbourhoods level, which is where Hackney becomes 8 or so neighbourhoods. So that's the sort of contextual background for anyone who's watching. Amy?
I completely agree with you, and I love that you've raised that. We will seek much further funding. I'm talking to the Neighbourhoods Programme at the moment about what that looks like for next year in terms of the business case that will go through ICB, and we would like to invest as much as we can in it. We've got some concrete plans now, so yeah, absolutely.
But Amy, in terms of how the neighbourhood system will work and how this interacts with children's or young people maternity services, what do we expect to see change for patients and residents in terms of pathways and what have you over the next year as the neighbourhood system embeds?
So it's different. So for 0 to 5s, it's quite integrated already, but the integration is around children's centres. So they have MATs and they have multi-agency working. So the bit there is, how do we bring in midwifery and health visiting and those services, and how do we link that around primary care and GPs, and how do we strengthen the relationship between GPs and the rest of the services working with the young family, and make sure that everybody knows who is working with the family, and particularly around early help. So for 5 to 19, so for that school age, those are the kids that primary care don't see as much, but schools do see. So it will be around strengthening the relationships between schools and GPs, so introducing them to each other, having decent pathways around that, thinking about how that might work, and also looking at that safeguarding and fast interface. And the last bit of work that we want to do, not counting the immunisation stuff, is around families. So there's adult primary care have had, sorry, I'm trying not to use too many acronyms now. Adult GPs and primary care have implemented MDMs, so multidisciplinary meetings, which have just got off the ground through COVID. They've done really well. We want to implement a families MDM, which is where so adult residents who are being discussed in their multidisciplinary meetings. If they have children, then we have children's practitioners there. Children's practitioners can work with the parents and with the agencies, working with the parents, so joining up as sort of a whole family approach in that multidisciplinary working. So most of it is about relationships, and most of it is just about joining and linking partners across some really specific areas. And then some of the pilot work we've been doing in the Northeast around immunisations, we'd like to roll out more widely.
Perfect. Thank you. Any other questions? We've got a few minutes left. Amy, I suppose one last one wrap up from me is in terms of where we are. Obviously, the GPs are voting on the new structure this week. And in terms of how your work stream then evolves forward, I think essentially, whereas we have 4 or 5 work streams at the moment, we go down to 3. Looking at the chart, the triangular chart, it looks as if this work stream remains largely intact, if that's right or not. So can you just say what changes you envisage as a result of that reorganisation?
So, I mean, in terms of this work stream, kids and families are in full-time education generally, or in childcare or in nursery. So it's always been quite integrated. It's worked closely with the local authority and City of London and our wider partners. So I envisage that will continue. I think the North East London interface has, I mentioned it earlier, strengthened around children during the pandemic, which has actually been helpful because some of the very specialist children's services we need support from our partners, if we need more capacity, if we haven't got enough beds, those sort of arrangements. So that's positive, I think. But I envisage that a lot of the work that we have started to progress, we'll be able to continue to do that with our partners, and then and continue to interface with now as appropriate, and where that is beneficial for us going forward.
Thank you very much indeed. Do I have any last questions before I move on to the next item on the agenda? I can't see everyone on the screen, so type into the question chat if you have a question. No, perfect. Well, thank you very much indeed, Amy, very much appreciated. Members of the CYP, thank you very much for attending. Because of these online meetings and timings, I sort of don't go through a round of introductions because it just takes up too much time, but thank you all very much for coming. And please feel free, CYP members, to leave the meeting, or if you'd like to stay for the next item, you're more than welcome. So thank you. So next item on the agenda is item number 5, which is the safeguarding report, the City and Hackney Safeguarding Adults report. We can see that on our page 19 of the agenda. And then we've actually got the annual report starting at page 27, and then followed by a strategic document at page 81. Can I please welcome Dr. Cooper, who's the independent chair of the board, and Denise D'Souza, who's our interim director of adult services. And we may also be joined by John Binding and Raina Griffiths. But Dr. Cooper, you're going to start off, I think, with a 5 to 10 minute presentation on the report.
Thank you, Chair. So hopefully everyone can hear me.
Yeah.
Clearly, thank you. So this, for colleagues who aren't aware, this is a statutory requirement of the Safeguarding Adult Board to produce an annual report, and in particular to be able to say what it is that has been achieved during the year between partners in terms of improving and delivering services to safeguard adults in the City and Hackney. I'm really grateful to bring the report here, because for me, one of the useful aspects of having an annual report is to be able to talk about what has been done through that partnership and get feedback from you about the areas that you might have interest or concerns with. So what the annual report does is 2 things. It presents the achievements of the board, but also the achievements of individual partners and what's been going on in terms of safeguarding activity across the City of London and Hackney. And so in terms of the activity levels, what we see in Hackney is very similar year on year in the terms of the types of abuse that are reported, which is neglect, self-neglect and financial abuse. This is very similar to the national profile. And similarly, the majority of abuse takes place in people's own homes rather than in institutional care. And that reflects the fact that City and Hackney don't have a lot of care homes, for example, within the area. There's some improvement in some of the issues that have been raised at the board previously. That's in terms of people getting feedback from referrals to the people who make those referrals or raise those concerns, and there has been some improvement there. We're now at 90% of cases where feedback goes back to the inquiry, and that's really important because I think it encourages a culture of saying, well, if you report a concern, you'll get feedback on it, you know something has happened. If you don't get feedback on it, there's a disincentive then next time in terms of raising any concern. So I'm pleased to see that gradual improvement. Moving on in terms of sort of achievements we've had in that past year, so this refers to 2019-2020, we published 2 safeguarding adult reviews. These are again a statutory requirement on the board to produce this. The first one was about Jojo, who was a woman with Down syndrome, very sad situation, very difficult case, but I think some very important learning, particularly for services who work with people with learning disabilities. The second safeguarding adult review was about Mr. Yee, and that was a really unusual review because we did it jointly with 3 other boroughs. It was a homeless man who moved between different parts of London, and the learning from that was really has been really useful in terms of improving how people who are homeless are safeguarding. Having said that, there is a forthcoming safeguarding adult review into the man who died last summer in Stoke Newington, because there's significant learning we're expecting to come out of that review. So we've also been working in this last year closely with partnerships with Community Safety and Children's on modern day slavery, and also particularly on transitional safeguarding, which I'm leading a subgroup on behalf of the 3 partnerships to look at the issues for young people who move between childhood and adulthood, and the safeguarding issues specifically raising for those young adults. I'm really pleased to report that our work with the community has shown improvement. We had another tranche of training for safeguarding champions, and they are absolutely critical in terms of developing awareness raising within different community groups across Hackney, and providing training, peer-to-peer training. We've also developed a peer-to-peer support mechanism, which we're now trying to recruit to. COVID has got a bit in the way of some of the work that we were planning to do this year. We've improved through the service user engagement task and finish group the ways in which we communicate with residents. So there's now a regular newsletter, and anyone who's involved in any of our work gets that. It's extremely accessible, and it tries to, as it were, translate what's quite often technical issues within safeguarding into a very accessible way for residents to be able to understand what safeguarding adults is all about. We have had last year a Safeguarding Awareness Week in November, and COVID permitting, there's another one planned for this year as well in November, and they were really useful in terms of promoting awareness on safeguarding adults and outreach into different communities and localities, and also supporting staff across all the range of agencies. Chair, you've referred to the strategy. Our strategy for the board was a 5-year strategy that expired this year, and so we spent some time during the last year consulting on a new strategy involving residents, professionals, using a number of different formats, and the new strategy is in your papers today. I also want to say that we're quite ambitious, and I'm not ashamed to say we are aim to do things that we haven't been able to achieve, because I think that's about stretching what we tried to do, and some of the things that we weren't successful with in last year we continue to try to achieve. So one of those was to recruit additional lay members for the board as one of a number of strategies to increase our resident participation. We have not been able to fill that post, but we will continue to try to do that. We're very aware that there's a need to improve people's awareness around assessing mental capacity, and particularly around higher executive functioning in mental capacity, and that's a piece of work that's continuing this year because we weren't able to get it off the ground from last year. So I think it would be fair to say we're still, there's still a long way to go in terms of what we're trying to do, but I would rather have an ambitious board that doesn't achieve everything than a complacent board that achieves everything it's set out to do. And that's my particular approach to the role that I've taken on for City and Hackney. So in this year, I've mentioned already the SAR, the Safeguarding Adult Review, which has got a focus on homelessness and safeguarding, Safeguarding Adults Week. And I suppose I'll just end up by saying, inevitably, COVID has had an impact on the Safeguarding Adult Board functioning, but we went online very promptly, and it have set up a more regular meeting of the executive part of the board, meeting monthly, specifically to look at how partners have maintained a focus on safeguarding adults through the COVID pandemic and lockdown. And we've done some really interesting work around trying to understand the impact of COVID in terms of safeguarding activity, and in terms of what types of issues, safeguarding issues, are exacerbated by, for example, the lockdown, or aspects of the impact of COVID. So only this week we were looking at a bit of a case study deep dive on COVID impact and trying to pull out some themes around what that might say in terms of messages to residents going into the second wave that may be useful for the board to promote across all its partnerships in terms of preventing the risks around COVID and safeguarding. So I just wanted to reassure the Commission that we've been working on particularly the impact of COVID in terms of safeguarding activity over the last 6 months. And there are in this group other people who are members of the board who can add and hopefully support any responses to questions that may be raised. Chair, I'm very happy to answer any questions about the report, the strategy, or our current work.
Thank you, Dr. Cooper. That was very helpful, and welcome to John Binding, who's the head of service for adult safeguarding, who's just joined as well. Members, I think I saw a question from Councillor Snell.
Okay, well, to be honest, I commended last year's report because I believe extra resources were put into this area and we saw a significant improvement in the quality of information given to us. I think you absolutely excelled yourselves this year. I mean, this is an absolute first-rate report, and in particular, what I respect, because the charity I chair is going through the same thing, is that, I mean, this is an absolute first-rate report, and in particular, what I respect, because the charity I chair is going through the same thing, is the clear work to review the governance and make yourselves more relevant and effective. So I absolutely commend that, and I hope you'll pass that back to your colleagues. I've got various questions, and I think they're quite simple, and they're about detail. The first is, if on page 32 of our agenda, you get the attendance from the different partners in adult safeguarding. And I know the work we've been trying to do in my ward, Dalston, around Gillette Square, we've been hampered by the fact the police are really difficult to get to meetings at the moment. And I think their engagement with adult safeguarding issues, particularly some of our vulnerable people out on the street, is absolutely essential. What I'm told is they're being distracted because they're doing social distancing and other measures. But are they committed? And is there anything we could do to get them along to more meetings? The thing also that I just don't understand is you talk about section 42 referrals. I mean, if I look at the table on page 51, there's all referrals, section 42, and accepted other inquiries. Now, can you just explain? I know section 42 is something to do with the Care Act, but can you just explain what those two categories are? Because it doesn't make a lot of sense without them. And then the last one, which I'd almost forgotten about, but you reminded me in what you just said, is when you were talking about higher executive capacity as one of the areas that you hadn't addressed. And I really appreciate you listing the stuff that you haven't done. I think that's very brave and an excellent thing to do. But I don't understand what that means. What's all that about? So thank you very much.
Thanks, Councillor Snell. Dr. Cooper, I think you said at the start you were working from page numbers on your report. Are you
yes,
okay?
but thank you.
Yeah, okay.
I think I can follow this. So I'll address some of the questions, but I'll call on John Binding, possibly with others. So in terms of police representation at the board, it has been sporadic, and not just that, there's been a real high turnover in personnel. So it has been problematic for Hackney. Less so in the city, because city police, this was raised by city colleagues, because city police come to the city subcommittee, which I'm happy with if they come there rather than to the main board. But we have had some issues. Although having said that, one of the things that we've done through the monthly meetings of the executive is challenge partners, and I say we because it's not just from me, as to their functioning in terms of frontline delivery through the pandemic. And there was some reassurance from police colleagues that their frontline delivery of services was not hugely affected by COVID. Now, this obviously is at a very high level, so I'm not going to provide that assurance to you, but one of the functions of those regular meetings was to have a conversation about whether adult safeguarding was in any way impacted by changes in how services were being delivered during the lockdown. So it's a bit of a mixed picture, and I can't give you absolute assurance, but only say that from the part of the board, we've been trying to hold partners to account to be able to say what have they been doing, and if there have been issues, what the mitigation is for example, any potential limitations. So hopefully that addresses your first question. Your second question on Section 42 inquiries and other inquiries, this is to do with the way in which the data is collected nationally by NHS Digital rather than some kind of local obscure definition. And it is to do with a technical interpretation of that data, which is actually interpreted somewhat differently across the country and is about to be changed in the longer term to be a bit clearer. But Jon, you might want to add something on that, and also on the higher executive capacity issue, which is technical, I appreciate, but absolutely critical in terms of understanding whether people, so my way of trying to explain it as a layperson perhaps is, if someone is making a decision about risk, that they really understand the implications of the decision that they're making, and does their behaviour, does their action demonstrate that they've really understood and taken that on board or not, and where people may have fluctuating mental capacity, or their mental capacity may be impacted on by substance misuse, drugs, alcohol, illness, diabetes, all sorts of issues that may affect their ability to make decisions. Are we therefore supporting them appropriately in making the right decisions in terms of risk, bearing in mind that there is positive risk taking as well as negative risk taking, and that safeguarding is about the ability to support people to live the lives they want to live. But I'll hand over to Jon and ask him to just address the other inquiries and the higher executive capacity, if you would, Jon.
Hi, good evening, everybody. So Jon Binding, Head of Adult Safeguarding for the Council. I would just add to the comment in relation to the engagement of the police. I think it's important to note that there's the strategic involvement about how we go about our business and what we do, and then there's the operational involvement. And what I would say is we've had very positive engagement at an operational level. There's never been any resistance to being involved in multidisciplinary meetings, and that I would say is also similar to their involvement in the domestic abuse service and all of those aspects to it. There were some anxieties a couple of years ago when there was a merging of the public protection units between ourselves and another borough, but there's been no detriment to that, is what I would say. And the notion from the police was always that actually we should be more available now, because the role is more specific to community safety and public protection. And that, I would say, is what we've seen. And we've seen more of a consistent staffing, almost, so we're able to name names within that service. Strategically, unfortunately, that always changes, and we don't always have an awful lot of control over that, as Dr. Cooper has said. So I just want to give that assurance. Operationally, no problem involvement with that. In terms of the Section 42.1 and the Section 42.2, it does sound a little bit, oh, what's that about? But it's about what used to be the notion of what was progressed as safeguarding and what wasn't progressed as safeguarding. So the Section 42.1 rather, is more about how you gather information before you make a decision to do what I would call the bells and whistles Section 42.2. So sometimes the decision might be to say might not be to say there's no further action, or it might be we might signpost somewhere. But another other inquiry might be, for example, in a residential home or a domiciliary care worker where there's perhaps been a missed visit, or it might be the worker said, I'm not happy with that person's attitude towards me. So we may not progress that as a full bells and whistles Section 42.2, but the other inquiry would then engage our quality assurance team, for example, to do that piece of work. Because we're not going to ignore it. Clearly there's an issue, and it might be a training issue, but it wouldn't be a full Section 42.2 inquiry. We get a lot of those that tend to come through mental health services. And sometimes that might be because the person doesn't want us to progress it as a safeguarding, but they're happy for us to do something else, which isn't a formal safeguarding. So it's good to see those in the figures. It's good. It shows an imaginative approach, and it shows an application of making safeguarding personal quite often. So it's not a bad thing, but it's just it's acknowledging that can be lots of other things that are available as opposed to a full bells and whistles Section 42.2. Is that okay? Is that
does so Jon, when we're looking at, say, on page 23 of your report, then just say if we look at 17.18, the concerns, there were 1,336, of which 482 went on to a 42, and then also 142 were the other type of inquiries you just alluded to. So of the 1,336, 482 go to section 42 and 142 go to other, but both come from the original figure of 1,336. Is that right?
Yeah. It's about the 1,3 odd is everything we get.
Fine.
Absolutely everything we get that's got safeguarding marked upon it, or we've had a referral which, through discussion, we've thought, no, this is what you're telling us is a safeguarding concern. So we'll put it in that format, and then the outcome will either be we didn't progress it any further, we signposted, we did other inquiries, or we progressed it as a full section 42.2. It's worth bearing our figures, as Adi alluded to earlier. There is a bit of a national issue about what we would call conversion rates. So what your rates are of how many of those concerns you've progressed on a full section 42.2. And for Hackney, we've stayed about a third. And that's kind of bang in the middle for most sort of boroughs across the country. So that's not a bad place to be. And we've done bits of audits as we've gone along to make sure we're getting those decisions right, and that nobody's been negatively affected by a case being progressed as an other inquiry. Is that okay?
Fine. Thanks. And did you want to add anything in terms of the high executive capacity?
Yeah, I think that the executive functioning and executive capacity, there's a phrase I've heard used a few times. I've not quite made my mind up whether I like it, but I think it's very descriptive. And sometimes it's about talking the talk, but walking the walk. And it might be you have somebody who is, this is the example I always give when talking to staff and colleagues. You might have somebody who's in their own home, who everything about that person's environment would suggest to you that all is not well, this person is not coping. And yet the conversation with the individual is saying to you, I'm perfectly fine, I'm absolutely great, and when you leave, I'm going to cook myself a 3-course meal, and I've got the next door neighbour coming round and we're playing bridge tonight, and you think, okay, but everything around you will be indicative of this person not being able to put what they're telling you or what they want into action. And so I think it's our concern sometimes is that we shouldn't always take things at face value. So there's been a number of safeguarding adults reviews nationally where people have gone in, had that conversation, and they've come out going, they seem fine to me. They had a lovely conversation, but clearly what they haven't done is dealt with it. Now, one area to add to that, our occupational therapy colleagues do an amazing job of I would call respectful challenge. So they would never go into someone's home and give an inappropriate equipment to somebody without doing that gentle conversation of, well, show me what you're able to do, because then we'll get the right equipment for you. And they wouldn't just go with somebody saying, oh, I'm fine, thank you, I want that piece of equipment. And we're not always that good at that. And I think also, as the STAR findings will show, sometimes that's about multidisciplinary working and we're all arriving at the same decision, which is around, you know what, this isn't quite coming together. And also being clear about legislation and to approach that either through court of protection or inherent jurisdiction. So I think it's something we're all struggling with, but it's all about those decision makers testing out when everything won't be okay for that individual. And it's a series of conversations to extract that.
Thanks, John. I've got Councillor Adams, and then I want to try and finish this item in about 5 minutes. So, any other questions now? I mean, Councillor Snell's were 3 excellent questions. Councillor Adams, anyone else to bring in? No. Oh, and Councillor David. So I'll take 2 questions in one go. Councillor Adams.
Yes. Good evening, everybody. Thank you for the report. My question is in connections with the 2 SARS review, Jojo and Yi. I'm just wondering if you could describe the changes with which services involved have been implemented as a result of the review, and any key learning points that you can tell us about.
And before you answer, Councillor David, your question?
Yeah, just out of curiosity, I know you've been speaking about the CARE Act. do you people deal with, does your department deal with the Mental Capacity Act as well? Yeah, I'll just leave it like that.
Okay, thank you.
So I'll start, and then I'm very happy for colleagues to join in. In terms of the impact of safeguarding adult reviews, I think there's two ways to look at this. One is about just getting the stories out there through all our partner organisations to more generally raise awareness about the range of issues that can cause problems for people, to raise further awareness. So even if you're not working, so if we take the JoJo SAR, even if you're not working in a service working with people with learning disabilities, there's still some learning from hearing that story about things like what's called professional curiosity, not taking on face value, a bit what Jon was just talking about now. So I think there's two levels at which I would say the safeguarding reviews have impact. One is a more general awareness raising about the complexity and issues and challenges for frontline staff in working together to achieve the right outcomes for the people they're working with. And that crosses over all staff, all volunteers, and a whole range of agencies and partners. And then the second is more specific, which is about, with every safeguarding adult review, there are a series of recommendations for particular agencies or partners that they then have to respond to and take actions to deliver. So whether that's changes in policies, procedures, training, the way they work together with other partners, and those specific actions are monitored through the Safeguarding Adult Review subgroup of the board to show that over the time those agencies and those recommendations have been delivered. So for example, there have been changes in the specific learning disability services in response to the JoJo SAR. In response to the homelessness SAR, we had a task and finish group looking at safeguarding and homelessness, which did make some really good changes in terms of raising awareness of the staff working across homelessness and safeguarding to be more understanding of the crossover issues and in effect work more directly with more directly together with people who have homelessness and safeguarding needs. But I'll ask Jon or Denise to respond a bit further to that. In response to the question about the Mental Capacity Act, certainly the Mental Capacity Act is definitely extremely relevant to safeguarding adults, as is a whole range of other legislation aside from the CARE Act, which gives us our primary safeguarding duties and responsibilities in law. So safeguarding, I would say, yes, it's in the CARE Act, but there are a whole range of other legal frameworks, including the Mental Capacity Act, which have a direct impact on anyone working in safeguarding activity. But I'll hand over to Jon or Denise to.
Thanks, Dr. Keeley. I've got a couple of minutes, please, Jon and Denise. So a couple of minutes just to wrap this item up.
Just very quickly, it says that the Mental Capacity Act, it's core business. It's absolutely core business in terms of what we do for adult social care and indeed our colleagues, and that is involved in the deprivation of liberty safeguards as well that we report in the annual report. For the SAR and the JoJo SAR and Mr. Yi SAR, I would echo really what Adi said there. Really is a series of, there are some actions we need to do collectively, and there are some that are specific to agencies. So one area for that, for example, is the district nursing service, is ensuring they're enhancing their knowledge of supporting people with learning disability in the community. So knowing that actually we have a specialist service and making sure those referrals and the engagement of advocacy. So we pushed advocacy more as well to ensure they're more involved in everyday business as we go about. I could talk for another hour, but I won't do. So the report, and we produced a seven minute document.
7 minute briefing, Jon.
Thank you. That's the one.
It's on the website.
But it's really good, and it's really good. You know, it's in bite-sized pieces, and it gives you the kind of key facts. And that's one of the things we're hoping to do more of as we go along. We discover that's a really good way of hitting home recommendations and findings.
Thanks, Jon. Thanks, Dr. Cooper. Yeah, can I echo Councillor Snell's comments? Thanks for a very clear report, and also for the very considered and informative way you've answered your questions today. So thank you very much to everyone there. So I'll bring that item to a close. Members, just before we go on to Catherine Pelly from the Homerton, I have asked David Mayer from the CCG to attend. I'm just going to call this now as AOB. Obviously, we had a discussion last time in terms of the CCG merger, however you want to call it, to North East London level. Since that point, you've had the copy of the proposed constitution and handbook circulated. The GPs are voting on it this week. So we're midway through the point when different GPs are voting. I've asked David just to come for 10 minutes now. If there are any further, and I see Mark's here as well, any further questions in case members have any particular questions, having now seen the documents. As I say, members of GPs are voting on it this week. I can probably ask a few, but I'll open it up if there's any other further questions from members. So David, if members come in, or just make a comment if you have a question. David, I mean, we spoke also late last week as well in terms of the possibilities. I mean, one of the concerns that I've always had is in terms of, whilst there's a commitment of 98% of funding that would come back down to the City and Hackney model, how do we future-proof that in terms of, say, 4 or 5 years? There's different people here. Can you what sort of reassurance or comment can you give in relation to that?
Thanks, Joe. Just on the voting, the voting actually opened today at the request of the London-wide LMC and local LMC. We extended the period of discussion and answering questions and queries with members, and it opened today and will conclude on Monday. I mean, I guess the allocation that we receive as a CCG is a capitated allocation. So the Department of Health and Social Care agree a formula for healthcare spend based on predominantly deprivation is the current model of how the resource flows. So as long as the Department of Health and Social Care continue to use a framework that weights investment in health on a capitated basis, then we should continue to receive the allocation as described in the documents that you've seen before. That's about as much assurance as I can put into it, and who knows what happens with the comprehensive spending review and so on. I can't see, I mean, I was reflecting on this today with our clinical exec. The deprivation indices for part of Hackney haven't moved in 10 years. That's the time I've been working in City and Hackney. So and most of them remain entrenched. So as long as that formula remains the same, then I expect the same the same amount of resource to flow to City and Hackney.
Can I just add to that that those allocations were published 2 years ago for 5 years, hence each year going up a little bit by various inflationary measures, I guess, etc. And so the undertaking is to stand by those for us, that 5-year plan, as it were, and that forms the 98% moving forward. Now, obviously, they only publish 5 years, and there's the NHS England now, and in the future, Parliament can always intervene in different ways. And that capitation formula does weight, as David says, deprivation. It also weights age profile as well. It has various kind of parameters that are put into it. But anyway, that's essentially what happens. As we know, new money coming into the system with support the long-term plan will be coming at the STP level, whatever we do, going to 7 or stay at 7 or go into 1. That's new money. So we are talking about the current allocations.
Thank you, Mark. And I think one of the things, David, when we spoke, just to sort of inform members, I think you were quite strongly making the point of that what this does in terms of bringing together the commissioners and the sort of the primary, the hospitals in terms of the big secondary care providers is, you would say, I think one of the advantages of this is it sort of does away with a degree of internal market and commissioning and seeks to reduce that, and that's something you would say to be welcome. Do you just want to expand a bit more upon that? Because I perhaps haven't fully appreciated that as possibly being one of the benefits.
So the derivative of the integrated care system model is the long-term plan, which was published by NHS England last year. And there was a side letter published with that letter from Simon Stevens, and indeed it was included in the foreword for the long-term plan, which set out an ask of Parliament to consider removing the Competition Act from any powers within the NHS ecosystem, and a revision of the Competition and Markets Authority's powers in relation to that market control. So it does inherently pull together providers and commissioners in a way that does completely erode the purchaser-provider model, which commissioning has been working on for some time. And I would view that as a benefit for North East London because of the strength of our anchor organisations working locally, our NHS providers. So yeah, it's a positive outcome from the long-term plan.
Thank you. Members, any other questions? I just wanted to give you the opportunity now you have the documents. Okay, well, thanks both for being prepared to come and for forwarding on the documents to us, and then we'll obviously await the outcome. And I think then, depending on what happens, it may be at some point, if it goes ahead, for the new structure to be explained and exactly who's on what different governance part of the triangle, so we can understand. I think it's fair to say, members, that a lot of focus in terms of day-to-day delivery will move essentially to the Tracy Fletcher's role as chief exec of the Homerton in terms of pulling providers together in the future, and so that will be so it may well be that in the future we have to have a separate item where we're asking Tracy about her work doing that, to hold her accountable in terms of what she's doing separate from her work of heading up the Homerton. But I think that briefing, as it were, maybe for another day, so members are fully versed on what the new structure may look like. Okay, well, thank you both very much. With that, then, can I draw that item to a close and go to item 6, which is the Homerton Quality Account? Can I welcome Catherine Pelly, the Chief Nurse and Director of Governance at the Homerton. We've got the report at item number 6. I think we forewarned Catherine that we may well have a few questions on COVID and where the Homerton is in terms of preparedness. Obviously, there's been some major achievements over the year in terms of the CQC outstanding, which we congratulate the hospital on, and also the immense work they've done during the COVID crisis. And also, I note the very much in touch leadership we have. The chief exec, I think, personally signing 4,000 cards to all staff in the last week, and that sort of leadership certainly goes noted. So, Catherine, over to you.
Good evening, everybody, and thank you for your time. Yeah, Tracy's had to have a week off because I think she's probably got RSI from signing. But anyway, so just by way of introduction, so I think I came last year to present the quality account. For members, just the quality account is a statutory reporting requirement for NHS Trust, setting out some specific aspects regarding the quality of our services. I think it's probably fair to say that this year's quality account is slightly different in nature because of the COVID pandemic. So there are regulations that set out exactly what we should be putting into our quality account, which does lend you to getting a very wordy document that sometimes is a bit impenetrable. And that's because actually in statute, the wording is written and we have to kind of follow that. But I'll come back to that in a second. We were told very late on in the year that we wouldn't have to produce a quality account because of the pandemic. So we all breathed a sigh of relief and kind of thought, oh, okay, that's fine. And then we were told we had to write one in about May, June time. But we were given some relaxation regarding some of the auditing requirements. So what you've got is we took a decision internally in the organisation that we would have a report that literally met the statutory requirements. We didn't have the capacity to make it anything more than that. Although I've got somebody writing a short summary, which as long as we don't run out of time, we'll go to annual members meeting next week, but we'll go out to our members and we'll be available. So we are recognising that we do need to turn 50 odd pages into 2 or 3 pages of summary. So the report format goes through our achievements, of which you've already noted, Ben, the outstanding hospital rating. First in North East London, it is a lovely privileged position to be in. It's a number of years of hard work, and we continue, and our aspiration is that the whole of the organisation becomes outstanding. But I think it's fair to say that actually we're probably in a unique position in terms of all the services being rated good and very, very little kind of concerns raised by our regulator. We set out some objectives last year. I think the report demonstrates we didn't meet all of those. And part of that, I think, was we'd set ourselves some stretching targets, but actually also really a lot of them were loaded that you're delivering quarter four. Quarter four got overtaken, as you know, by the pandemic. We started work on pandemic work in January when we were screening patients from coming from abroad. So it wasn't just something that hit us in March or and into April. But actually, when you look at the achievements across the rest of the measures, there's a huge amount of success. We've had letters, obviously, from yourself on behalf of the Scrutiny. We've had from CCG and HealthWatch, and there is a plan that we will formally respond to those. The report only got finished last week. It'll be laid before Parliament in the next few weeks, as it has to be. And so we will write a formal response to you, picking up all your comments. And I am minded that you probably want to talk more about COVID than anything else. So I wasn't probably going to say much more, but happy to take any specific questions. But as I said, you will get a formal response from me answering your very specific questions, as will the CCG and HealthWatch.
Thanks, Catherine. Can I just start off before I open up to members? And in terms of COVID planning for second wave, can you just give an overview of where we are in terms of numbers in the hospital at the moment? What your capacity could stretch up to? Are we looking again about children's paediatrics going off to BARTs? Are we looking at elective surgeries being cancelled? Where are we on that? And also, I think one of the questions I've asked, where are we on discharge to care homes and testing, getting a test result back prior to discharge to care homes?
Okay, so COVID. I think just take us slightly a little bit further back. Just we, for those of you who may or will remember, when we were in the peak in April, we went from 8 ITU beds to 30 in a matter of days, and ran at a very high kind of intensity. And we've managed hundreds of patients that were seen, treated and discharged. And sadly, we lost 151 patients and we lost 3 members of staff. So that's kind of the backdrop. We've spent the summer rebuilding and restarting services in line with the infection control guidance, which has changed a couple of times, and in line with trying to get and catch up and deal with the backlog, particularly of elective procedures. We're managing that. We're doing particularly well, and actually, if you compare us to where other providers across London, we're doing extremely well. It is not without challenge, but we've kind of managed to do that. And there are pathways for patients. So if you are having a planned procedure, there's an expectation that you are swabbed 3 days before your procedure. You have to follow some rules around self-isolation, and then you come in and you are not exposed to people who have come in as an emergency. And then our emergency flow through ED has got a kind of what we refer to as red and green pathways, so we can take you in based on what we think your COVID risk is. And in fact, at the moment, we've got some building work going on in our ED funded by Department of Health to make that even more secure from a separation of infection control practices. And then patients go through the hospital depending on where their risk is, their COVID status, etc. And there's mechanisms for that for paediatrics and for maternity and for NICU. And I was struggling to join the call earlier. I had some technical issues. I'm sat at home, but the questions about maternity, we are allowing visiting in maternity. There are restrictions, but we were one of the first trusts in London to open up our maternity to better and more exposed visiting. And in fact, my head of midwifery is on a London-wide group looking at how we can maintain visiting as much as practically as possible and safe. We're very keen that it's an important part of an experience. So that's kind of where we are. We've got a COVID preparation group which meets twice a week, and we look at a whole sort of things about what the current situation in the hospital is, what do we think is coming down the line in terms of the numbers of patients in the community, what we're seeing in other hospitals, what the impact of further lockdown arrangements may or may not be, what do we need to communicate to our staff, because they're having to follow an awful lot of rules. If you come onto site, and we'd ask you only to come if you need to, but if you come onto site, there is ways of being screened as you come onto site. Everybody's expected to wear a mask. You will walk around the site, and I would say that every member of staff is wearing a mask consistently wherever they are across the site. So the whole set of rules that are having to follow, and we're trying to kind of maintain them and be assured about that. So that's what that group looks at. We've got a set of mechanisms of communicating with our staff. Emails, webinars, I've done a video, we're going to do all sorts of different kind of things, and we're trying to make it a little bit kind of quirky at times, so we're tweeting a bit and trying to help people remember, because this is really, really hard for everybody. Where are we today? So we're in a relatively good position. We have, well, as of the 8 o'clock bed report this morning, and I think it's still the same, there were no COVID positive patients in our ITU. ITU's got 11 patients in it, but none of them have got COVID. We had one confirmed case in a medical bed, and we have a number of patients that were waiting for results. And some of those may be people who will end up with a negative swab, but they're clinically COVID. There is a group of patients that do meet that criteria. And we've had small numbers going through maternity. So earlier this week, we had 2 women in labour who had COVID positive swabs, and we've had 1 child. We're seeing a different case mix, but it's not overwhelming us currently, which is allowing us to maintain the rest of our activity, particularly the elective and the planned and the outpatients. We're reminding our community staff particularly that they're probably more at risk now, because actually it's more people in the communities. You'll hear from Sandra when she comes on. Actually, that's where, from a staff perspective, that's where our risk is. My screen has come back, but I hope you can still hear me. We look at the data every single day, and we track the data regarding the patient and our staff in terms of absence affected by COVID and what that means as well. So there's quite a lot of activity just trying to track absolutely everything. So that's kind of where we're at. You asked specifically, didn't you, about care homes? So patients have to be swabbed before they leave. If their discharge destination is a care home or a hospice, we are doing that, and we've got a good turnaround time. It's about 24 hours. The results coming back from the Royal London, we're meeting that. It's not causing us a problem at the moment. It is not delaying discharges. If there is a delay, but the patient needs to go because actually that's better for them, there is a way of managing that with the care homes. They go into isolation anyway, and that's in agreement with the care home, and that's not been a problem for us. I think it's also fair to say that we've done 2 rounds of patient testing at Mary Seacole, have all been negative, which is a real indictment of how well they are managing the infection control risk, because we've got visiting going on, and we're kind of trying to keep normal life going in Mary Seacole. So the fact that no patients have got COVID in the home in 2 rounds of testing is really, really positive.
Can I just explain, members? Mary Seacole is one of 4 main care homes in Hackney, of which the Homerton is essentially in control of that.
Yeah. So we run Mary Seacole. Yeah, sorry, should have made that a bit clearer. But yeah, so and all the other care homes will be tested through the Pillar 2 route as well. There's an agreement, and we are about to start our asymptomatic staff testing at Mary Seacole in line with those regulations.
So just on that point, Catherine, how frequently will the staff get tested, say at Mary Seacole?
I think it's weekly, but I can confirm that, but I'm almost certain it's weekly. There's so much testing going on, I can't. Yeah, it's weekly. We're doing monthly for patients, so we're following the rules that's set by the Adult Social Care Inspectorate at the Care Quality Commission. So we took a little bit of time getting the staff testing up and running, because we didn't want to impact on capacity, but we needed to understand the risk if we find a lot of asymptomatic staff who then have to go off. What does that mean?
And just on the testing question, how frequently are the staff at the Homerton getting tested?
Right. So we're not testing asymptomatic staff at the Homerton. There is no requirement for us to do that at the moment. So staff that are symptomatic get diverted through the Pillar 2 testing, which is the national testing route, and there's a process of doing that, and it links into Test and Trace and the app, etc. There is no asymptomatic staff testing, and there's a number of reasons for that. Across North East London, we agreed that we wouldn't roll out asymptomatic testing until we were confident that the patient testing on the symptomatic was robust, and it's vulnerable. There's so much testing going on for patients that it's quite vulnerable, and there's been some lab issues, and if you want a lot of patients through your door, there's a lot of testing, so we didn't want to put that at risk for asymptomatic staff testing. We anticipate being told nationally at some point to do asymptomatic staff testing, so we're prepared as best we can be, but I think it's a concern, the impact it'll have on overall testing capacity. So you asked about discharge to assess as well. So quite a lot of rules changed around discharge in the early days of COVID in the attempt to get as many patients out of hospital to free up hospital beds. So we made some changes as we had to, and we're following national policies regarding that. But the changes that have been made around discharge to assess are not having an impact, where there's PPE available for people to go into homes to do those assessments. And it's working quite well, and as the guidance comes through, we are following that, and we've got good arrangements. Actually, the biggest challenge around our discharges this week has been the cyber attack on the council, but we've worked through that as well. So we're managing to find solutions, I suppose. Every time there's something that's changed or guidance or something to implement, there's kind of a set of activities we kind of get out on top of it and work through that. And we're blessed with a great group of staff who are very flexible and responsive across all our services and have been all the way through. It's National AHP Day today, and we spent this morning celebrating how our AHPs responded by going to work with the district nurses, coming into ITU, going into environments they weren't used to, doing stuff online. So people have been really, really, really flexible and positive, and it's been humbling actually to kind of watch how people have just got on with what's been a very difficult time.
Thank you, Catherine. All of that was incredibly helpful. I've got 4 people wishing to ask questions and 10 minutes left. So I'm going to take all 4 questions together and then go to Catherine to answer them. Can I just ask, I think Catherine was having problems getting in at the start. Please, the cyber attack is still an active investigation, so no questions in relation to that, please. There will become a point when we can ask questions, but not now. So in the order that they come, and then I'll take all 4 questions. Please keep them brief, everybody. Malcolm Alexander, your question first.
Okay, just a couple of points really. One, the question is, with a new wave of COVID, is there a risk of exhaustion of staff, because staff have been through a lot, and I just wondered how staff are going to cope with a new wave as it seems to be happening. But the other thing I just want to mention is that later on the report, one of the things about the quality account is the opportunity to put priorities in the report to the trust, and we put a number. Health Watch put a number of priorities there, which I know you're going to answer. But one of them, which is really important, is the development of St Leonard's Hospital in relation to the really outstanding community services we have there, with a building which has fallen to pieces. And I think this is really going to be a priority for the Homerton and for the area for the future.
Okay.
And those are the sort of 2 points I really want to make. Yeah.
Thank you, Malcolm. Let me go next to Cllr Gordon. Cllr Gordon. Okay, I'll move on. Cllr Snell.
I was disappointed, given that the chair had written to you on the 4th of September, that no reference was made to the status of the Coordinate My Care software and whether we're keeping it up to date. I mean, our end of life study concluded that was really important. It really allowed people to end their lives in the way that they wanted to. And I'd have thought it's become even more important to ensure that those records are up to date in a time of COVID, when we know it's the most vulnerable. You know, the people who are at risk of death are considerably higher than they were at the time. So can we just have a little bit of reassurance that that is still up to speed, that GPs are doing what they're supposed to, that they're all keeping those records up to date, and if anything, that it's being expanded at this time?
Thank you, Councillor. Councillor Gordon.
Thank you, Chair. I'm sorry, I was kicked out of the meeting for a minute. It may have been answered, but I mean, my question was also about asymptomatic testing for staff, including contracted staff, because I was concerned to hear that this isn't in place yet, and I wonder when it can be. And I know that universities are managing to do that, and I mean, and we do hear conflicting reports about the prevalence and, you know, the importance of asymptomatic transmission. So, I mean, it may have been covered in the bit of the meeting I was kicked out, and I'd be very interested to hear about when that's planned to be put in place, because I know that universities have done it.
Thanks, Councillor Gordon. Yes, we did cover it, but I think Catherine can very quickly just repeat the response in relation to that. And then Jon Williams, final question.
Thanks. Yeah, it's just we had an exchange of emails with Tom Nettle, the Director of Workforce and Organisation Development in the summer, and he was very reassuring in terms of kind of the way Homerton had done risk assessments on all staff, including the contracted staff in ISSS. And I was just wondering, given the risk that you're going into a second wave at the moment, just how you're going to be updating those risk assessments to ensure that they're effective. Thanks.
Thank you. And just before Catherine answers, I think Sandra Husbands, our Director of Public Health, would like to make a brief comment. I've lost you, Sandra. I can't hear you for some reason.
Thank you, Chair. I can make the comment after Catherine's finished answering the questions. I just wanted to say it before she leaves, if that's okay.
Fine. Okay, let's do that. Over to you, Catherine.
Okay, thank you. So I'll take them from the beginning. So Malcolm, how the exhausted staff. So I think one of the things that we tried to do as soon as we possibly could in the summer was encourage our staff to take their annual leave. That's been a challenge because none of us have been able to go anywhere. But we have made it, and actually we made a commitment that we would ask staff to have taken at least 40% of their annual leave before the end of September. They should have taken 50%, but we recognise that. And actually in the main, most people have. So we've encouraged people to take a break because I think it's really, really important. We've done a huge amount of work around wellbeing. One of the things we've learned about this virus is the impact on our staff. We've lost colleagues. We've had to watch people deal with some really difficult things. We've got our Talk Changes service who are providing bespoke support services. We've done a massive amount around wellbeing. Last week was Recognition Week. We've been going around saying lots of thank yous and the cards from Tracy and free breakfasts and ongoing. All of that, I think, boosts morale. It is really, really tough. And you know, we need to keep going and making sure that we're communicating and engaging with our staff. I think how they're going to cope, we're going to have to just keep helping and supporting them, recognizing that actually we're all finding this very, very difficult. You know, my personal experience, I've got a child in Nottingham, has been in a third week of self-isolation. It's really, really difficult. You know, we're all faced with our own story. The more we're open about that and how we're coping, I think is really, really helpful. So that's the yes, Malcolm, the St Leonard's conversation. We are part of, you know, the wider work in City and Hackney about where all the estate that we have comes into play around what services and what the care and health services in City and Hackney will look like in the future. And I think, you know, we need to pick some of that up and take it forward.
Yeah, I think Malcolm, certainly I think we'll pick that up at a suitable point in our agenda as well.
Yeah. So just around the coordinate, Micah, I think should be clear, well, when we got the responses from everybody to the account, I did go back and say we would formally write to everybody when the account was finished, and we will. But I think the coordinate my care, we are using it, and it's been reviewed, and we're trying to look now at further processes to develop how that could be used and the benefit of coordinate my care. It is in place, and it is being used, but there's always room for improvement. Just on the asymptomatic staff testing, there isn't an expectation that we asymptomatically test. The logistics of testing 4,000 staff plus our contracted staff is a significant amount of work. This is 2 swabs. This is not, and then we've got to work out what we're going to do if we lose percentage of them and we've still got services to deliver. It needs to be thought through. And then we've also got to put that into the capacity question. It's not that we don't want to do it, we need to do this safely, and we need to understand why we're doing it and how often we're going to do it. And there's conversations about making that across North East London rather than that. So that's part of it. But testing capacity is a risk, and we can't put the patient capacity at risk by testing staff at the moment. And the risk assessment. So yes, so we did a risk assessment around COVID risk on every single member of staff. So it linked to some of the BAME work that we learned about COVID, and our contractors, so ISS and ERS and Steris, who are big providers, confirmed that they'd also done those risk assessments as well. They used the tool that they had, but we shared ours with them. That's a dynamic process. Some people won't necessarily need their risk assessment updating. And some people will, as we're trying to kind of get people back on site more, social distancing, COVID secure workplace, we have to go through all of that. We also have to consider what it might mean should there be further changes to lockdown and things like that. So it's an ongoing dialogue between manager and member of staff, and there are processes to follow that. And we've got weekly webinars run on COVID HR issues, which pick up some of those things. I think that's all my questions.
That was. Thank you, Catherine. That's brilliant. And just before you leave, I think Dr. Sandra Husbands would like to say a word.
Yeah, thank you, Chair. I just wanted to express our gratitude to Catherine and colleagues, and particularly Sally Rumbold, for arranging flu vaccinations for social care staff. They were specifically excluded. I mean, as in, I think they weren't thought about in the national guidance, and Homerton has come to the rescue and made some provision for social care staff locally. And I just wanted to acknowledge publicly that that's what's happened and say thank you.
It's okay, no problem.
Thank you.
A little bit of logistics to sort out, but yeah, no, we got there.
Thank you. And it was good to see. I guess Ed from the Citizen is probably watching. It was good to see the story and putting about the importance of people getting their flu vaccine and playing, as a Citizen always does, play a good public service role there.
Absolutely. So, 20% of our staff were immunised in week 1, so we're going in the right direction. Still more to do. I was jabbing our exec yesterday, so if anybody wants their flu jab, I'm your woman.
Thank you, Catherine. That was very informative. So I'll bring this item to a close. Thanks for all your hard work and everyone at the Homerton. And now the final substantive item 7, will go on to Dr. Sandra Husbands, our Director of Public Health, to give us an update on where we are with COVID in the borough, track and trace, and other issues. Dr. Husbands.
Thank you. So I'm just going to present the slides. So just bear with me while. Okay. So I'm sure you'll all know that the situation across the whole of England, well, in fact, across the whole of the UK and across the whole of Europe, has been getting worse in terms of COVID cases on the rise. And these slides that I've got here is just to illustrate to you what's been going on with us locally. And then right at the end, I'll tell you a little bit about what we're doing locally with contact tracing. So I apologise for the fact that the colours could be better distinguished for those of you who have red-green colour blindness, but we've just taken the slides directly from the Public Health England document, didn't prepare the graphs ourselves. So for those of you who can see them, the red line is England, the green line is Hackney, and the blue one is London. And for those who can't, in the top graph, which is the cases per 100,000, this middle line here, that's the Hackney one. The top one there is England, and the bottom one is London. So what it's showing you is that this lump back here, green lump back here, that's when we had that peak in the summer when we had the outbreak that was really confined to the north of the borough. But that in the last, excuse me, in the last 2 to 3 weeks, sorry, in the last 2 to 3 weeks, we've had an exponential rise. Actually, as has everywhere else, although our curve has been steeper. So we've actually gotten a much higher incidence rate than most other London boroughs, and our most recent 7-day incidence rate is, as you can see from the slide, 129 per 100,000.
And Dr. Husbands, just to point out, that's only going up to the 6th of October, so it could be higher still, depending on where we are.
Yeah. So so there's a little note at the bottom making the point about the reporting delay, but you're right. It is only going up to the 6th of October, So that's telling us where we're going with cases. Obviously, it's important to understand that in the context of how many people are being tested, which is the middle graph, and also the percentage of those tests that are coming back positive. So at the beginning of the graph here, we're at the beginning of May, and so this is when, as we were coming down the peak of the pandemic, and you can see we were across the whole of England, there was like just around 5% positive, and in London and Hackney it was only around 2.5%, and now we are around 10.5% today. In fact, I'm not sure if it quite shows it on this graph, but our positivity rate is about 10.5%, which is significantly higher than in London, for London and for most other London boroughs. To put this in the wider context, though, so yes, we're doing quite badly. When I say doing badly, I mean as in the incidence rate is high. Yep. The 7-day incidence rate for the whole of London is around 94 per 100,000. If you remember, and we'll come to it on another slide, with the contain framework, above 50 per 100,000 was the rate at which areas were going to be put into areas of intervention. So other parts of the country that have already gone into local restrictions before this latest restriction framework came into force yesterday. So places like Leicester and Blackburn with Darwin, and places that were subject to local restrictions from weeks or months ago, went into those restrictions at a much lower incidence rate than we're currently at, or than London is currently at. But that is telling us something about the whole context with where we are with the whole country. So we've already got 12 other London boroughs over 100 per 100,000 incidents this week, including us, of course. 12 London boroughs, not 12 others. And all but the City of London are over 50 per 100,000. So we anticipate that the whole of London will be above the 100 per 100,000 rate by the time we reach the end of this week. And that it's likely that there will be some conversation at the national gold meeting, the number 10 gold meeting on Thursday, about what to do with London. But to put that in context, though, as it says on the second bullet point there, other areas like Nottingham, Knowsley, Liverpool, much higher incidence rates, and also we're not having the very high rates of admissions to hospital or ITU admissions like they're having in Liverpool or Manchester. So the community transmission is happening at a high rate, but it hasn't yet translated into high hospital admissions. We're still predominantly seeing the cases happening in younger people, but as the spread has gone on, through the community, we're seeing it spilling over into older age groups, and so if you look at the two population pyramids there, the first one, the one to the left, is all of the weeks except a bit before the last 14 days, and the one to the right is the most recent 14 days. And so that shows you that across the whole of the outbreak, we saw a kind of a spread across the whole of the population, but still with an emphasis on younger people, but that in more recent days it's not confined to, but mostly affecting younger people. But if you remember when we talked about this last time, there were far fewer cases in the older age groups. It was really the 20 to 39-year-olds. I'll just have to do this so you can see the map. And what this is showing is that we're still seeing some clusters happening in the north of the borough, but we're also seeing them in all over the place, in various other parts of the borough as well. So we've had an increase in cases and clusters that are not just confined to the north, but spreading out all across the whole of Hackney, really. Very little of Hackney has been spared, but the majority of cases are not clusters. So we were looking at a lot of household clusters in the north of the borough to begin with, and now we're seeing the majority of cases are individual cases, not linked to households specifically. Obviously people live in households, but there's not like a cluster of cases in a household. It's only 14% are identified as household clusters by their postcodes or the way that they present. And that headline is actually slightly incorrect, because we still have the 3 wards in the north of the borough with the highest incidence rates. This is the table I was referring to earlier that shows you the contained framework levels, and which is different from the restriction levels. It's a bit unfortunate that they kind of call them similar things, but so as you can see, we've got several of our wards over 100,000 incidents, and most of them over 50 per 100,000, which is this area of intervention level that we're talking about here. And so then to understand, so what does that mean in terms of, are people getting sick? Has there been an increase in hospital admissions, healthcare utilisation, the sort of indicators that are telling us that this is not just community transmission amongst people who are well and staying well, but is this spilling over into something more serious? So we haven't had the admissions, and as we've heard from Catherine, it sounds like they are gearing up and really ready, but we have had an increase in suspected cases being diagnosed by GPs, and also in 111 calls. 111 calls that are COVID related. So there's some activity that leads us to suspect that this is moving in the direction of people becoming more ill. And these are the sort of indicators that they saw in other parts of the country before they then started to see people getting sick and going into hospital. So it's not, the pattern tends to be that, a couple of weeks or, maybe 3 weeks later, maybe you start to see people admitted to hospital, and then you see the people being really sick, and then a few weeks later start to see, unfortunately, if people do get very sick and admitted to intensive care, that then bleeds into more people dying. It's not a given, and we have the opportunity still, despite how bad things are looking, to try and intervene and do something about it. And it's not hard and fast, so that time frame isn't set. It's just the pattern that we've seen elsewhere.
Dr. Husbands, sorry, just on that last slide, though, we actually see a slight decrease on all 3 of those measures.
Yes.
Going into end of September, start of October.
Yeah.
Any comment on that as to why we see that?
I can't really say why we see that, because the case numbers are still going up, even though those things seem to have been going down a bit.
Thank you.
So one of the things that we can do, obviously, is make contact tracing work more effectively, and that's one of the ways that we've been trying to support that is with our what was being called locally supported contact tracing, and they now have a new name for it, which has gone completely out of my head because I only read it this afternoon for the first time. But anyway, it's the local end of the test and trace system. So we set that up in City and Hackney, and it started about 3 weeks ago. So currently, test and trace, NHS test and trace, are only contacting about between 70 and 74% of cases in Hackney and City. So that's people who test positive. And then of those people's contacts whom they identify, they are reaching an even lower percentage. And in Hackney, it was only around 50% at one stage. It went up slightly, and then since test and trace since the numbers have got very, the incidence has gone up everywhere, and test and trace got really busy. Actually, they've been struggling themselves with trying to keep up with that demand. So at local level, what our role is to try and bridge that gap between the 70 to 75% of cases that they can contact and the 30% or so that they have difficulty in contacting first time, or for the first 24 hours, I should say. So they send us the information about all of those cases after 24 hours and how many attempts they've made to contact them, and then we make our attempts locally. So we've got slightly different approaches, single system, but slightly different approaches in Hackney and City. So in the City, environmental health officers are doing the follow-up with cases, doing the telephone calls, and in Hackney we're using customer service staff who've been using the staff who were staffing the 311 helpline, and who've all been trained in making every contact count, and very familiar with the more sort of motivational type of conversation. So we're still building, and obviously we've had a bit of disruption this week because of the cyber attack, and that has meant not that we couldn't do the work, but that we've had to go back to Public Health England with a new IP address, which they then have to give permission to send the data to, and all this kind of stuff. So actually our IT team was absolutely brilliant at finding a way to put us back online in terms of contact tracing, more or less, I was going to say immediately, but certainly within the day. But we're waiting on PHE to come back to us. But up until the beginning of the week, the team was actually working on and building on very quickly getting to grips with just a handful of people. In fact, to begin with, we only trained 6 people. They were getting small numbers of cases to begin with, and then it suddenly got very, very busy, and they went from doing 3 or 6 cases a day to 70 in one day, and they managed. We still are developing the system. How do we work to finally make contact with people that we can't reach by phone and things like that. So there's still a bit of more work to do. It's all supported by the public health team, so that the HOs obviously are very experienced in doing contact tracing, etc. But both the HOs, City HOs, and the Hackney customer service staff have access to public health team for further support. And then, of course, if we need to, if there are complex cases, we escalate those to Public Health England.
Just on that, Dr. Husbands, where are we sort of on successful conversion rates with the with the contact tracing, and how does it differ between sort of us using, or Hackney using customer service staff, City using environmental health officers, and I think Tower Hamlets possibly using staff at the neighbourhood level, if I recall correctly. What's the most successful, or is it much of a likeness?
I couldn't tell you what the Tower Hamlets success rate is. They've had very few cases in the city, so it's not a reasonable comparison. with our system in Hackney, in the first week, they reached 54% of cases. Where they've not been able to reach people, so obviously this is a time-limited endeavour. So where they've not been able to reach people, there's been a combination of either the system couldn't provide correct information, so we really couldn't reach people, or people didn't answer. So how it works is they get sent a text. Shall I come back on camera? That we use the information that we have to send people a text saying you will get a telephone call, this is who it's going to come from, this is the number, and this is what it's about, which is a sort of a way of kind of warming them up and motivating them to actually respond and answer the phone call. And that's been quite good at getting people to answer the call. But where we've ended up not being able to reach people by phone, we up till now haven't had a then go and knock on the door approach, and that's what we're developing at the moment.
Lovely. Thank you, Dr. Husbands. I've got 5 minutes left, and if you don't mind me, Councillor Kennedy's just sort of from his latest briefing just said we've got out of 356 contacts, we've so far contacted 140. Was his latest information. I've got a question from Councillor Snell, and I've got a comment from Mark Rickets. Councillor Snell.
Yes, the minutes where Chris Lovett ably took your place at the last health scrutiny meeting. What he talked about, and I hoped it would be in your report tonight, was contact with the NHS to see if we couldn't track them down using our records, whether we could actually have access to NHS records that then would give us another line of defence in contacting these people. Has there been any progress on that?
We are still developing the system, so it's not as straightforward as just saying, oh, can we have your records? But Andrew Trathan, the consultant who's leading on this, is looking into all of those issues. But quite often it's not that we don't have the information. I think the majority of the time that we don't contact people is that they didn't pick up the phone, and there'll be all sorts of reasons for that, like they were busy, and as opposed to, or that we didn't have their correct details. But yes, we are looking into triangulating all of the data, NHS data as well.
Thank you. Dr. Rickets, Mark Johnson.
Well, it's just in relation to, you know, the slide you said with the 3 lines that had a blip and have gone down a bit. It's in relation to that, my understanding is that the up spike in 111 and GP primary care activity corresponded to when the schools went back. And lots of children who hadn't been at school for a long time suddenly started to kind of share all their usual viruses in a very rapid time space. Added to which was a lot of people then saying, oh my goodness, has my child got COVID? I need a test. What do you think, doctor? Da, da, da. So a lot of people ringing on and ringing primary care, you know, disproportionately large on top of a disproportionate hump in viral activity. I would just say that just in terms of a kind of a bit like the messaging around the flu and encouraging people to have their flu jabs, it's a bit like just want to take the opportunity to say that, you know, in children under the age of 12, COVID very rarely causes a serious illness. And if your child's got a snotty nose and a fever, it's highly unlikely to be due to COVID. It's highly likely to be due to some other virus. Like it is. And actually, and if a child is actually jolly unwell with a very high fever and not drinking, and they're not passing urine, and they're not, you know, they are still highly unlikely to have COVID. But they need to be seen to check them out for some other condition. So I just wanted to give those sorts of messages as well on the back of that.
Thanks. That's actually you're right. I think that's helpful. It also coincided with the time when it was difficult to get a test. That hump as well, didn't it? So
yeah. Thank you. Right. Very last question I've got from Cllr Gordon, and then I'll wrap this up. Cllr Gordon, can you make it quick, please?
Sorry. Thanks very much, Chair. I'm afraid I was probably one of those parents, but Yeah, I just wondered whether you had any information or a view on the sort of, I don't know whether it's the right word, but the vector of transmission. I mean, you're saying that these aren't necessarily household clusters. That possibly suggests these aren't household transmissions. Do you know how people are catching COVID in Hackney? How much information do you have about that, and what's your view?
So the majority of, so when you look at contacts of cases, the majority of contacts are in households, but there are people who catch COVID from other people. So wherever there's a household cluster, the first person in that house to catch it caught it somewhere outside of the household. So there'll be people who are catching it at work. We've had a few workplace clusters and outbreaks. There'll be people who are catching it through socializing, either in another household or through meeting friends or other people elsewhere. And it's actually difficult to pinpoint exactly. From around the middle of August, NHS Test and Trace has been trying to pin down the sources of infection, but first of all, it's very difficult to do that, and secondly, they've been under pressure themselves just in terms of following up cases and getting them self-isolating and identifying all their contacts and following them up. So that hasn't worked out in terms of giving us that information in the way that we'd all hoped. But it's not possible to say that there's one or two things that, or one or two places, or one or two types of activity that are causing COVID to spread. But it's just kind of, it's down to reason really, that if one person in a household gets COVID, that nearly everyone else is going to get it.
Thank you, Dr. Husbands. Thank you, Catherine Pelly, as well. Thanks, everybody. Draw that item to a close. Thanks for everyone's hard work. Dr. Husbands, if you are able to keep giving us updates and come to our November meeting for a further update as well, that would be much appreciated. Item 8 is the minutes. Can I take those as read, please, members? Thank you. Item 9, work programme. I mean, I want to remain iterative. I think we'll have Dr. Husbands next time. We've got an item on unplanned care, which will obviously, depending on how A&Es are doing. I'm trying to organise an item specifically on care homes so we fully understand the entire pathway and make sure everything is being done, and maybe looking at examples from elsewhere, bearing in mind the significant instances we had in our care homes last time. We're going to have an update on the digital, our digital review about access to GP care, and the interim director of adult social care will also give us an update about the new management structure there. So that's what we've got planned for November. But with that, I'll thank everyone and close the meeting. Thank you. Thank you.
Thanks all.
Thanks, Ben.
Thank you. Bye.